For our first talk, we have a special treat for you. We have Professor Henrik Kehlet from Copenhagen University, who is like the world expert on post-surgical pain. And he has written hundreds of articles on risk of chronic pain, many predictive studies looking at post-surgical pain. And so he's the perfect person to introduce us to the concept of pain vulnerability. Welcome, Henrik.
Thank you, Franziska, for this introduction and also to invite me for this special symposium. I think I'm only invited to give a warm-up because my topic is chronic pain, but in a very special situation where we have the patients to identify before they get the injury that leads to persistent pain. So it gives a fantastic opportunity to identify what is the role of pain vulnerability versus a lot of other factors. So the topic is well known, and it has been established in so many publications, reviews, and everybody agree that this is a very important clinical problem because, as you can see in the slide here, it is a significant proportion of patients who will complain of persistent pain after almost every type of surgery, and especially a lot of the common operations as shown on this slide. So the question is, why? And then it begins to be complicated. And I think the rest of this symposium is complicated. What is the role of preoperative pain intensity? What is the role of psychological factors? What is the role of nociceptive function? What is the role of the type of surgical trauma? Is it all due to a nerve injury and neuropathic pain state? What about treatment efficacy on acute post-op pain? What is the role of disease? Because we may have some cancer operations and we may have some clean surgical trauma as a hernia operation. What is the role of adjuvant therapy? Or is it all in the genetics? And I look forward to the other lectures on that point. But I think we shouldn't be disappointed because it is very complicated. So to dissect it down, it's clear that we have a role of patient-related factors and surgical treatment-related factors in this specific clinical situation of development of persistent chronic pain. So first of all, a little about the assessment. Although it should be very simple, most of the studies have an insufficient methodology of assessing pain after the operation. And we have to be much more specific, as emphasized recently. We are talking about pain in the surgical area that develops or increases post-operatively. We have to identify the period before we call it chronic pain. IASP has a definition 2 to 3 months. But in certain operations where you have implantation of a mesh or so and a pronounced inflammatory response, it probably has to be 6 months. Is it a pain continuation or is it a new pain? Is it referred pain? And what other causes could cause the persistent pain, like infection, cancer recurrence, etc.? Again, showing how complicated it are. So therefore, we have to have some validated procedure-specific assessment tools. And again, remember, this is much more simple than other chronic pain conditions. And still here, we have a lot of problems. We have different outcome domains, physical functioning, pain, of course, assessed during defined function, and also a lot about socioeconomic consequences, which is really important. So how many assessment tools validated do we have in this specific condition? despite that everybody agree of the relevance of the problem, we have very few. In hernia surgery, there are 3 validated assessment tools, also including the functional consequences. In breast cancer, despite of so many articles, only 1 from our group has been validated, and the same applies to thoracic surgery, which is a well-known model for really moderate to severe persistent pain. So overall, only 5 of these models with well-defined, validated assessment of the pain, also in relation to well-defined function and their consequences. So what about the pathogenesis? I think this is what it's all about in this symposium here. What is the role of all the different pathogenic factors I showed you on the second slide? Now, when you operate everywhere in the body, there is a risk of nerve injury, of course. Some nerves are big, some nerves are small, and it appears that the larger the nerve, the higher the risk of persistent pain, and especially in nerves with both sensory and motor function. So I've just listed here some of the important nerves in different operations in the body, but it applies to everywhere in the body. So the question is really, what is the relative role in the persistent post-surgical pain state of a neuropathic pain or a nociceptive pain? It's still an open question, mostly because the lack of high-quality methodological studies. There was a review a few years ago in Pain where they summarized, based on almost 300 studies on the topic and in 11 types of surgery, that in persistent pain patients, the neuropathic component was probably most important in about 2/3 of the patients after thoracic surgery, the same amount after breast cancer surgery, less so in hernia surgery, and in hip and knee operations, which is very common and have a lot of persistent pain problems, the neuropathic component was about 6%, or in other studies up to about 10%. But the most important conclusion was that we need to have more detailed, high-quality methodological studies, which will include quantitative sensory testing before and after the operation to find out really what is going on here. And there are extremely few studies here. I will show you probably the first one that came out, a very large study 5 years ago we did in collaboration with a Dutch hernia center in Stuttgart, in more than 400 patients operated with well-defined surgical technique, either laparoscopic or open, and about 12% developed moderate to severe pain postoperatively. And interesting for the discussion in this symposium, we also tested all these patients with quantitative sensory testing before and half a year after the operation, including the pain response to a heat stimulation, and that was predictive in that particular model. But in other models like knee replacement, a couple of studies now have shown that it doesn't apply to that operation. And I will come back to what is the problem mechanism for this discrepancy. Now, interestingly, there were 2 types of surgery. One has a smaller risk of nerve injury in the 3 nerves running in the surgical field. Again, interesting, the quantitative sensory testing in Germany was totally similar in the patients operated in Copenhagen. But postoperatively, there was a difference in persistent pain in that the laparoscopic ones had less persistent pain. And it was documented clearly by the QST that there was also less signs of nerve injury, indicating that nerve injury is an important mechanism The high-intensity persistent pain was especially reduced by the laparoscopic technique. So it supports that, at least in this operation, the nerve injury is important, and we know what to do to reduce the problem. Now, post-mastectomy pain has been repeatedly demonstrated to be a significant problem. There are several nerves, and especially if you operate in the axilla to clear the involved lymph nodes, the intercostal brachial nerve is at risk. Here we need much more detailed quantitative sensory studies. And the question is really, should we preserve that nerve or should we transect it? But this is difficult because you have these metastatic lymph nodes in the field. So that's an open question that needs further study. Now, post-thoracotomy persistent pain is really well established and a significant problem. So compared to the hernia data where we had minimal invasive surgery, probably with nerve-sparing techniques, what about the new developments of video-assisted thoracic surgery, which is without a rib retractor and therefore potentially to avoid the nerve injury to the intercostal nerve? We have no randomized study with similar pathology. We have a potential lower risk, especially from a recent paper we have submitted with QST before and after, suggesting that the nerve injury with these minimal invasive techniques is with less significance and less development of persistent pain, which is really important. So we can conclude here that nerve injury is an important but insufficient factor for persistent post-surgical pain development. And then we get closer to the topic of this symposium. What are the other factors that may contribute to the development of persistent post-surgical pain? Now, psychological factors has also been studied a lot, but unfortunately mostly in retrospective studies without less data on the preoperative psychological status. There's a lot of studies, different assessment systems. Anxiety and pain catastrophizing usually comes out as really important predictors, and pain catastrophizing probably with the highest predictive utility. But again, we have to be careful because this is probably procedure dependence. If we look at patients undergoing hip and knee arthroplasty, it has been repeatedly published and documented that pain catastrophizing is an important independent predictor of chronic pain. And these patients have a relatively high prevalence of pain catastrophizing before the injury. But as I said before, we have to be careful because in hernia surgery, persistent pain is a significant clinical problem. But the role of psychological factors is much smaller because these patients don't really show the pain vulnerability except when you give them a heat stimulation before. They don't show up with all these psychological risk factors as anxiety and pain catastrophizing. And there is a couple of studies as shown in this slide to support this conclusion. But let's move a little more to the pain vulnerability. What is the role of preoperative pain for developing persistent post-surgical pain? Well, this has been demonstrated in so many studies across procedures. Preoperative pain correlates with developments of persistent pain. Preoperative pain syndromes with chronic pain in other areas of the body than where we operate also correlate in most types of surgery. That means patients with headache, low back pain, etc., that is also associated with a higher risk of persistent pain. And that may reflect something about pain vulnerability. Now, to make it a little more complicated, we again know from so many studies that acute postoperative pain, the intensity correlates again to development of persistent pain across procedures. And then comes the really important question. Is it so that the acute pain causes chronic pain because of different types of neuroplastic pain response, which is so commonly discussed? Or is it so that preoperative factors, pain vulnerability or other factors, may determine the risk of acute as well as persistent pain? And this has obviously created a lot of studies, especially for anesthesiologists, to study whether intensified acute postoperative pain management could reduce the risk of persistent pain. But having been involved in that research for 20 years, I think it has been totally disappointing that so far we have no final conclusion that this may really reduce persistent pain. So we come back here. Is there an inherited propensity for developing central sensitization? We will hear more about that. And does this convey the increased risk of pain, hypersensitivity, and risk of chronification, either assessed preoperatively or late postoperatively? I think it's even more complicated. As a surgeon, we need to be pragmatic and simple-minded, because is it a purely peripheral problem, or what is the relative role of central mechanisms? From hernia surgery, we have many studies to show that a reoperation with neurectomy and removal of the inflammatory mass around the mesh can eliminate the persistent pain in about 30–40% of patients, supporting that this is a peripheral problem. But we have also some very interesting data from the complicated situation of a hip and knee arthroplasty. No, I went to the wrong direction. This is some studies from Irene Tracy's group, where they took patients undergoing hip arthroplasty and assessed their gray matter volume by imaging techniques. And we know from other studies, especially from Vanya Abkarian's studies, that in persistent chronic pain situations, the gray volume is reduced. And this was confirmed in this group of patients having chronic pain from their hip arthrosis. But then they were operated and their pain was reduced, and then they re-investigated and found out that the gray matter volume increased, supporting that at least in some patients this is a peripheral problem and less so a pain vulnerability problem. Very new studies from Lars Nielsen's and Thomas Graf Nielsen's group in the western part of Denmark have also supported to this very interesting area, studying patients before and after hip and knee arthroplasty. And their studies suggest that the central pain processes are maintained by a peripheral input, but they show signs of pain sensitization before the injury. But we have to be careful, because these studies are done in patients with a successful operation to relieve pain, and not in all those studies where the pain is continuing. So this is again an open question. It just opened up that in some patients, the peripheral input after the operation is really important to continue the persistent or avoid the persistent pain state. So this was a short introduction, and it just shows that even in a simple situation like surgery and the risk of persistent pain, it is so complicated. We have the peripheral afferent input with different causes for a continuous input. We have all what is going on in the central sensitization in the spinal cord and higher brain centers, psychosocial risk factors, whatever that can be and be caused of, and then of course genetic factors, which we will hear more about. The final conclusion is really that surgery is a very interesting model to study mechanisms for development of chronic pain. Because, as I said in the beginning, we have the patients before the problem occurs. But as you can see, even there, it is really complicated. And we need much more studies with an optimized methodology, inclusion of all pre, intra, and postoperative risk factors. And then on a procedure-specific basis, because these patients are different between procedures and diseases. And we have a couple of genetic studies now, as we have published a couple of, but so far they have made no really clinical relevant clues to these risk factors. It's only a small proportion that can be explained. Thank you very much.